and get this thing rolling. It has perturbed me to no end that we've had time for all sorts of things this summer, but we have been able to continue our work with this very important topic of mental health. And I would like to, unless somebody's got some burning urgency to speak, I'd like to go ahead and get started right now with our a question or maybe an answer as to where we stand budgetarily. We had a pretty good year this past year in 2020. But Mike, I think you're going to update us on where we stand from a budgetary standpoint for behavioral health services after the special session.
Yes, Mr. Chairman. Let me go ahead and share my screen. And can everybody see it?
Looks good.
Great.
Got it.
For some reason, it slowed my computer down. Anyway, so what I'm going to do today is just provide a high-level overview of where we are with mental health services and the budget update. So I think the last time that I probably presented to kind of give you an update, things were not looking great. Much of what had been added in the past session was basically kind of frozen or unallotted for what the governor had actions had taken to respond to the COVID-19 pandemic. But now after the special session, we're in a little bit better place. So looking at this slide, just a quick summary. As you recall, in the previous session, the 2020 session, there were quite a lot of investments in behavioral health. And then at the reconvened session, everything kind of stopped at the end of session as the pandemic became a major problem. And then the issue is that the governor had to freeze almost all new spending. It was about $2.1 billion back in the reconvened session in April, of which about $442 million was in the HHR area. And there was well over $135 million of that was for community-based services. So at that point, the appropriation was not removed, it was just unallotted. That basically just meant that it was frozen until subsequent action was taken. So advancing to August, when the governor introduced his budget for the special session, which was House Bill 5005 and Senate Bill 5015, essentially in that proposal for the unallotments in HHR, it had eliminated pretty much all the $442 million. There was only one small pass to a $50,000 that was retained. So that's basically what the Senate and the House worked with, and as they worked through that budget process, the positive thing is that there was some additional savings identified, as well as some of the unappropriated balance that had been left. Those things combined in the final conference report resulted in about $222 million in general funds. Much of it were the unallotments of items that were restored. We did have savings of almost $145 million that helped offset that. So there was a net increase of $77.6 million general fund in the compared to the governor's introduced budget for the special session. And the savings that had been identified was mainly for managed care rates and Medicaid. There was a reduction for this fiscal year compared to what was budgeted. And so those savings helped to, I think, guide the decision-making to restore some of the items in HHR. So moving to the next slide. So this just kind of summarizes the community behavioral health services. If you look at it, so what it basically shows you are the items, what the governor's introduced budget, where he had removed the appropriations for them. You can see the little check boxes just kind of as a reminder that they were originally unallotted in the chapter that passed the 2020 session, chapter 1289. And then you can see the amounts that were restored. So for Step Virginia, the second year amount of $30.2 million was fully restored. For permanent supportive housing, $20 million of the $25.5 million is fully restored. And that includes the full $17 million in the second year. So that will carry forward in the base going forward. For discharge assistance planning, which is an important funding source to transition individuals to state hospitals, 17.5 million of the 20 million was fully restored. Then the pilot projects with hospitals to reduce census pressure. This was a $15 million initiative, which half of it was restored in the special session. This was to kind of work with private hospitals to help find other ways to divert individuals from the state hospitals for TDOs. You also see the Virginia Mental Health Access Program. This is the program that basically is increasing supports and access of pediatricians to mental health professionals so that they can better treat children with mental health issues in the primary care setting. This is actually fully restored as of January 1st. So the first year, half the funding was restored. So from that point on, it will actually be funded to be statewide. And the last item here is the forensic discharge planning in jails. This was expanding the number to 3 jails. This one, there wasn't sufficient funding to restore. So that's just to note that, and that may be an outstanding issue, especially looking at those issues going forward. This slide for STEP Virginia funding status, it basically just takes that 30.2 million that I just mentioned was restored. It just shows you how it's laid out between the various services. So the first column is just the base funding that was already in the 2-year biennial budget, and the session had added 54 million, and the 30.2 million is restored. So the only piece of it that wasn't restored at all was any of the administrative costs that DBHTS had for administering STEP Virginia. And that may be just an issue to continue to look at going forward. So other behavioral health funding actions. So in this slide, you can see Medicaid redesign. So this was sort of or Medicaid enhancement, has different names. Was looking at the community-based services of Medicaid. You could actually include this in the total of community-based services because they are community-based, but it was just put here separately because it's Medicaid. And you can see that for the second year, the full amount is restored. Only the first year amount was not, and so that was being phased in. But hopefully they can initiate it in the second year and proceed with that redesign, which is actually tied in and aligned with a lot of the activities at DBHDS. The second one here is professional mental health Medicaid rates. So this increased the rates to 110% of Medicare. The second year amount, it was restored. So as of July 1 of next year, those rates would go up to 110% of Medicare. And this builds off of the 2019 session when the General Assembly increased the rates to 100% of Medicare. And the idea here is to try to entice more individuals into providing mental health services. The third item here is the Behavioral Health Loan Repayment Program. This is something back in 2016, the General Assembly had directed the Department of Health to look at and develop, and they actually did with a stakeholder group, developed a proposal for a repayment program. This past session was finally the General Assembly did take action to create it. However, there wasn't sufficient funding to restore it at this point, but this is something that will probably continue to be looked at as you all are well aware of the issues with the workforce and behavioral health and trying to expand that. And lastly, here was transportation from state hospitals after a TDO commitment. This was something I know that this joint subcommittee has looked at, that once someone completes a TDO, if they've been transported far away from home, it's sometimes hard to get them back. Oftentimes the CSBs they may have to drive across the state to get them and take them back home. So this was the idea of looking at the alternative transportation and seeing if you can't factor this into that so that people have a way to get back to their communities. And the bottom part of this chart just shows you behavioral health facilities. So these are the facilities themselves. The first one is the Virginia Center for Behavioral Health Rehabilitation. This was related to the operating cost of its expansion as the new facility, the new building comes online. That had been unallotted and was removed, and in the special session, no action was taken to restore it at this point. And then the last three related to the state hospital, security, staffing, pharmacy costs, and the clinical staff at the Commonwealth Center for Children and Adolescents. Those were all additional operating costs really related to the census pressures that had been imposed on them. However, again, there wasn't sufficient focus or sufficient funding in the General Assembly or the special session to restore all that. So that they may have ongoing pressures there as well. Pretty much, I think the focus during special session and I know especially on the Senate side, but eventually when it got to conference with the House side, the top priority, and I know, our chair and Senator Howe had, stressed that mental health community mental health services was one of the highest priorities that we were trying to address. And that's what I think you see reflected. The focus is the restoration on the community side, but there may be some need to provide additional funds going forward on the facility side, depending on what happens with the census. Other budget actions, this just notes one of them, mental health alert system, or otherwise known as the Marcus Alert. So the bill was passed in the special session. From a budget perspective, what was provided was $3.2 million. That funds 2 positions at the Department of Behavioral Health and Criminal Justice Services to kind of implement and administer program. It also provides $3 million in the second year, FY22, to fund basically one of the programs or teams in each of the 5 regions that as DBHGS classifies. So each region would get $600,000 to start one. And so again, I think as more work and planning occurs between now and next summer, other needs will probably be identified as this moves closer and closer to an implementation. A key thing to note is that the restoration of Step Virginia crisis services, especially the mobile crisis teams, was kind of a key component of this, and will also help in supporting implementation of that legislation to help boost the response capabilities. The last thing I would note, and this is not necessarily for this legislation, but because there were multiple pieces of criminal justice reform legislation during the special session, there was $3 million in general funds for a total of $6 million over the biennium that was put in central appropriations. This was just kind of like a reserve because some of the legislation, the fiscal impacts were a little unclear. So some funding was put back there just in case it needs to be provided to support any of those initiatives. It technically could include this bill, but it's probably intended more for some of the other legislation. But I just wanted to point that out that there is a little bit of some reserve in case additional funding is really needed. And this is just the last thing I'll talk about. So this is looking forward to the 2021 session. So the governor, since he just got a budget from the General Assembly in the special session, he is still developing his budget to be introduced basically on December 16th, 1 month from now. So as of I believe it was last Friday, or maybe it was 2 Fridays ago, but agencies were allowed to submit budget requests. And so what you see here are some of the ones from the Department of Behavioral Health and Developmental Services related to behavioral health. They have other ones, but this is mainly related to behavioral mental health. So you'll see that from the request, they do have stuff related to the administration of Step Virginia, which, as you recall, the General Assembly was not able to restore any of that funding, as well as some of the costs related to the Marcus Alert legislation as well. And I won't go through each one of these. I just wanted to kind of give you an idea of what they're requesting. Like I said, it's a very short time period to develop a budget, but there's also stuff where they want training funds to support the behavioral health redesign or enhancement, and as well as COVID-19 impacts, such as the hazard pay and increasing surveillance at the facilities for COVID-19, as well as pharmacy costs for state facilities, which is something that the General Assembly was not able to restore. That just kind of gives you a flavor of some of their requests. So with that, Mr. Chairman, that kind of covers the high-level budget overview. I think you're still muted, Senator Deeds.
I apologize.
That's okay.
I guess you House guys are used to all this Zoom, these meetings by Zoom, but those of us in the Senate are more in person. Us older people, I guess, we need these in-person meetings. Commissioner Land, you're out there, and Mike, I want to start off the questions by asking about this money you've got for the redefine TDO to exclude dementia from the mental health definition in TDO. Is this idea here to further reduce the number of TDOs that we've got waiting in emergency rooms?
Senator Dees, yeah, Mr. Chairman, I believe so. I haven't looked at it in great detail, so the commissioner can certainly elaborate. But I believe the intent is to kind of focus on dementia outside of that process. I believe it may be to contract maybe with hospitals or other entities to try to divert them from that so that they don't end up in the state hospitals. But I think it is one more initiative to try to alleviate that pressure. But
Anecdotally, I hear enough about people that are struggling with dementia who wind up going through the TDO process. And I don't think that's what the TDO process is meant for. I'm just kind of surprised it takes almost $10 million to exclude those people from TDOs. Are there other questions? Commissioner Land, if you want to save that for your presentation, you're coming next. That's fine.
Okay, or I don't know. Can you hear me? I just want to make sure I was off of double mute.
I can hear you.
Okay, so the idea is that folks who have a primary diagnosis of dementia, it's not a psychiatric condition. It's a medical condition, and we need to be managing those patients in the appropriate setting. And so we will have to. There's considerable issues with the current nursing homes and assisted livings and how they're able to manage some of the behaviors that come with that. And so that's how they end up in the ED and then TDO to a state facility. So we will have to build the programs to and help support them to put the supports and services that this population will need in place, because that's not included in a nursing home Medicaid rate to do that. So it is looking to find a way to get them in the appropriate setting in the community, close to home, so that their families can be involved and in the right setting, as opposed to locked in a state psychiatric facility. And a lot of times too, when we have a increase, our geriatric census is incredibly high and approaches over 110% routinely, which moves them into to adult beds, which then puts them even outside of a geriatric setting with other geriatric patients, which then becomes a real safety issue as well. So really needing to focus on this and hoping we can get some traction with it this year, because it's not a psychiatric issue for these patients, it's a medical issue, and we need to do something to alleviate that. And it will in turn alleviate census at the state hospital.
Okay. Are there other questions for Mike Tweedy relative to his budget presentation? The next, if they're not, the next up very appropriately, Commissioner Land, it is you to give us an update on where you stand in the midst of this pandemic. It seems like every week we get email from you that outlines the dire situation you've got in some of the hospitals, primarily because of this crisis in geriatric care, but also because you occasionally have to deal with the virus in one facility or another.
Yeah, and I was trying to get my video camera but I think that I have to have permission potentially from your staff to turn on my camera so you can see me and I can see you. Yes, the host. Okay, start my video. There we go. Still saying it can't. Let me try one more time. It's saying it failed to start, cannot start. Okay. Well, but can we get my presentation loaded or share it on the screen? Is Sarah there? Okay.
I am. I'm sorry, Sarah Stanton. Was either Heidi or Mira available to run your presentation, or do you need us to do that?
I can do it. Just give me a second.
Okay.
Thanks.
Mr. Chairman, now seems to be the time to ask Senator Barker a question. He Looks like he's under the interrogation lights.
Senator Mason, you have a question for Senator Barker.
No, sir, he just looked like he was under pressure there with the interrogation lights, and that'd be a good time to get one to him.
He's always under pressure.
Okay, there are the slides. So is it Mira that's sharing?
No, I think
Oh,
Heidi
let's-
is.
Okay, we can go to the next slide, the first slide. Okay, so thank you, Mr. Chairman and members of the Joint Subcommittee for inviting me to speak with you today. And this presentation is going to focus, like the chairman asked for, the census crisis and COVID-19, which along with the DOJ settlement agreement are my three highest priorities and for the agency as well, and that we're managing today. And we're also going to provide an update on post-2020 session activity, so you can see on the agenda. So we'll have a pretty full agenda, and if you need me to stop in the middle and ask any questions, or if you need me to speed it up, you can just give me a shout out and we'll do that. Next slide, please, Heidi. So first we're going to talk about the state hospital census. Next slide. And so here is an updated snapshot of our census that's by year. So this is full fiscal year 2020. And you can see that the ratio of TDO admissions between DBHDS facilities and private hospitals has remained roughly the same despite the pandemic. We're still staying around 25% of all the volume. And our trend, our actual totals actually are staying around 25,000. We had a little bit of a reduction at the beginning of the pandemic. And then of course, due to our closure temporarily to admissions in 5 of our facilities, has also impacted the total number of patients. So we serve about, continuing around 1,500 additional individuals per year than where we were. And it is, but again, stays fairly level. And but also in this TDO number, about 81% of the TDO admissions to the state hospitals are civil TDOs as opposed to forensic. Next slide, please. Okay, and so here's where I was talking about kind of the impact of COVID on the TDO admissions to the state hospitals. And you can see that the census has fluctuated considerably during the different phases of the pandemic. So initially, with the stay-in-place order, there was a substantial decrease in census for March through May. And then DBHDS also was proactive in implementing aggressive census reduction procedures, including discharge planning and EDL reduction. In April, we saw fewer crisis evaluations than any other month in recent memory. And our geriatric beds decreased less than the adult beds because these individuals, as we were just talking about, are much harder to place in the community. And so by default, they end up in our state facilities. There was a census uptick at the start of summer, which we normally see when, with the kids particularly. And so that also coincided with the reopening, and it led to a severe census crisis. So where we would typically see the kids' numbers drop off, everybody was at home, and so it was, a problem. To mitigate the impact of the increasing census, we actually worked with the administration, and the governor did issue Executive Order 70 in mid-August, on August 17th. And the order directed that when state hospitals are operating at 100% of their total bed capacity, they'll not serve as the facility of temporary detention for individuals who are not under emergency custody. And the order also recognized that and encouraged law enforcement to ensure a bed is available before taking a new admission to the state hospital and transferring that patient. It also required timely updating of the statewide acute psychiatric bed registry and put some communication timeframes around state hospital discharges so that we could free beds for new state hospital admissions. And you'll see that when we began experiencing large outbreaks, then in the next month, September and October, the closure of those facilities temporarily significantly reduced the census as well, because we had to work hand in hand with VDH to make sure that all of the patients were quarantined and isolated and fully recovered before they would allow us to restart admissions. And so that's kind of how that slide went. It's just been up and down like a roller coaster for us, but we are still managing through it. Next slide, please.
Commissioner Land, could I ask you a question about that?
Sure.
All of the people that are in custody weren't subject to the ECO, the emergency custody order. So how many people do you think, in August and September and then October, how many people so far have been affected by that? The people that aren't subject to an ECO but are in custody and are in need of a hospital bed.
So we worked extensively with the private facilities to do contracts and to help them manage to take the patients to medical beds with a consultation, psychiatric consultation services available to them so they could go ahead and be treated. And while they were waiting for us to free up that next bed, it actually got down to, in many cases, that we'd be able to get one out to take one in. So we do know that there were delays. We did not stop admissions, except for in the facilities where they VDH asked us and told us we needed to close. But we diverted across the state until we were at 100% in every facility before the first person wasn't accepted. And then it was just temporarily while we worked with administration and the private facilities on whatever type of rate that they needed for one-to-one, for psychiatric consults to help defray those costs because they were not meeting a medical necessity for an acute medical need to be and couldn't bill for it. And so we were working day in, day out, and the staff did a great job on helping to manage that. But we do know there were delays, but we do not believe that there were anybody streeted, and it was a delay, strictly a delay, and we did admit everybody that we could possibly admit as soon as we could.
Yes, ma'am. I know we've been in a dire situation this summer. There was a lot of misunderstanding. There were stories that I heard about deputy sheriffs waiting in emergency rooms way past the 8 hours to try to get a room. And my understanding is they don't have the authority to hold people in custody more than 8 hours.
Mm-hmm. Well, they did work with us and partner with us, and I know that a lot of them did stay longer than 8 hours, and that it was a real impact to them. And we were just going as fast as we could to get the bed, but we couldn't discharge people without a safe discharge to free the bed. So it was, we had to work on both ends of it, to do the best for the most, and to keep our staff and the patients that we had in our care safe as well. So hope that was.
Yes, ma'am. Thank you.
Okay. So on this next slide is our census on November 12th, and you can see the 3 facilities that have a hold. So Southern Virginia had an outbreak, and we had to close actually on the 12th, about 9 p.m. on the 12th. And then Southwestern Virginia has been on hold for several weeks. CCCA is back open, but we actually lost a ton of staff during that outbreak, and we were only staffed at 38% when we were given the green light to reopen. And so we're steadily working back up and anticipate that we'll be at 50% by December 1st. So by the end of this month, we'll be up to 50%. And we have been successful in signing a contract with a large system that does have child and adolescent services and has 5 different facilities. So we did a system level contract, and so we're getting some relief there. We've actually seen that with the reopening of PGH, Southern Virginia had reopened and is now back closed again. So we had seen that the wait times of any delays for the adult patients, we were not seeing any. It's really at this point mainly children that are being delayed, but we have been able to get some contracts in place, so we think that that will work out as well, work down the wait. And we have opened. We were at 18, and then we went to 20 and 22, and we'll be at 24 in the next 2 weeks. And so we feel like that we're making progress, and so hopefully the children will stop having to wait as well. But our ability to quarantine and isolate is greatly reduced when we have these outbreaks and the other facilities start to fill up. So typically, so the 5 facilities that we actually had to put admission holds on were, of course, Piedmont Geriatric, Northern Virginia, CCCA, and then Southern Virginia and Southwestern, which are currently still in there. We also had outbreaks at 4 others. We currently have at VCDR, Eastern State, and Central State, and FEVTC also had an outbreak. But we work closely with VDH and the local health departments so that we're being sure to manage those. And right now at Southwestern, I was trying to look and see in my notes, it looks like we have 49 patients and 30 staff at Southwest, and 9 patients and 5 staff at Southern Virginia. But we're always working with VDH, and they're helping us with testing and all, and helping us work it through just as quickly as we can, but we can't do it before it's safe. And so that's why we have to work hand in hand with VDH to make sure we're following all the guidance. Next slide, please, Todd. So here's the number of patients, these geriatric patients that were admitted year over year, and you can see, and this slide and the next couple of slides, we're going to dig down into some of the special populations, and so starting here with the geriatric, and they've increased for FY 2020, even accounting for the temporary drop in April that we saw on that previous slide. And we have geriatric beds in 4 of our hospitals, Piedmont, of course, Eastern State, Catawba, and Southwest Virginia. But even before the admissions hold at Piedmont Geriatric, which was the first outbreak that we had, the geriatric units were over capacity across the state. And when they're over census, that's when we have to start using those adult beds, which decreases the capacity for adults, but also is not a safe alternative to put them who are many times frail, elderly with medical conditions, as well as there's some psychiatric or behavioral issues in with an adult population is not safe. So we've worked and have actually done some contracts with nursing facilities and ALF, memory care facilities, to either divert or step down our geriatric patients, and have had some success there. We're also currently looking at a model that's been used in Connecticut very successfully to develop services for this population, and hope that we can have them come potentially to Virginia, or see if we can develop that with some of the partners here that are currently in Virginia, and really make a positive impact.
Mr. Chairman, this is Emmett. Is it proper to ask a question now?
Hanger, go ahead. Yes.
Thank you. Mr. Of the 602 age 65 and over, do you know how many have a primary diagnosis of dementia?
So when we looked, it was close to 500. I think it was 492.
Okay, thank you.
So we have a lot of patients that are primary diagnosis of dementia. And Heidi or Mira, keep me honest if that's not the right number. Check while I keep on, and will correct me if I'm wrong, but I do believe that that's right. Let's see. So we've talked a little bit about it already, but that definition of mental illness in Virginia does include individuals with a primary diagnosis of dementia, which is not a mental illness. And so, again, we're going to be looking for ways that we can potentially update that definition to better align with our current definitions of mental illness, and in order to facilitate better care for those who have dementia and co-occurring behaviors or challenges that they are currently sending them into our mental health facilities. So again, you're gonna see and hear me talk about that some this year ongoing. Next slide, please. That next population I wanted to talk about was child and adolescents and the number of admissions to CCCA you can see on the chart. And the trends continue to be concerning. Even without that COVID-19 drop, the FY 2020 numbers likely would have rivaled or even exceeded FY 2019. So we're continuing to see growing numbers. And then we did have to close in September on the 9th, CCCA to admissions. We were able to open, like I had mentioned, later that month on a limited basis. So we're having historically low staffing levels, but we are working really hard to restore that staffing, like I said, by December 1st. And we're also, again, we're working with our community partners to develop contracts and RFP for inpatient beds. We have had that one system that we've already been able to contract on an emergency basis with the CCCA staffing issues. So all of these efforts support increased throughput for the state service delivery system. So we're looking for, can we, front door and back door, can we divert or can we step down to increase our throughput? So you'll also continue to hear me talking about that and working with our private partners to try to get some relief. Next slide, please, Heidi. So the state facilities have been really proactive and persistent, and really it was remarkable how they kind of held back the tide of COVID-19 for those first 3 to 4 months of the pandemic. We did put strict visitation restrictions in place in March, and we also implemented very aggressive plans for infection control and isolation of both presumptive positive and positive cases, just to be very sure and safe, as safe as we could be. And again, I would just say I'm extremely proud of what the staff and the facilities were able to accomplish. And that in turn has made the challenge of shifting our stance from preventing it to fighting it, actually having active cases and outbreaks far smoother, because we've gotten really good at managing it. But it's just that community spread, it just brings it in. It's not the patients giving it to each other. It's, you have that community spread that we're experiencing across the Commonwealth and across our nation, really. So our current operational guidance includes delaying, again, those admissions at 100% of census in accordance with the executive order, and we will not accept a positive patient. We do have patients who become positive, but we cannot take a patient that we know is positive into the state hospital.
Mr. Chairman.
Mm-hmm. Okay. Go ahead.
Mr. Chairman, if you're speaking, I'm not hearing you.
Delegate Bell, sure.
I have a question of a bullet point she made. Would you rather we wait till she's done? Or
Yeah, that's fine.
All right, ma'am, I'm sorry to back up. I was sort of processing what you said. And then with regards to the visitation restrictions, many of us have a little more experience with how the jails are handling it. In other words, they've had in there, you usually are having non-contact visits. It's through a phone, through a piece of glass, but they're set up that way. They've been set up that way for years because of lawyers needing to see clients. Can you share with us, in other words, if someone is in for a very brief stay, I assume that the visitation is very limited, but for some of your longer term clients, the visitation would be important. You may not be set up to have this, talk to somebody through a telephone like so many of the jails can. Can you maybe just share how that's working?
Yeah, so We did allow visitation of parents to the CCCA, the child and adolescent population, and of course, any kind of legal or other types of visits are being held, but we've restricted the visitation. We do telephonic, we're able to do video calls, sort of like this, for them to be able to see family. And of course, if there's someone who's on a on a hospice type situation that are in our facilities, and that does happen, especially in those geriatric units. We have been able to make some ability for that to happen. Just it's just the right thing to do. But in practice, we are not having visitation, just normal visitation into the state facility, so we don't have those issues.
Mr. Chair, could I have a follow-up?
Mm-hmm.
Ma'am, so and maybe again, I think that we have understandings of some things, but not others. With pre-COVID, were there lots of visitors? So were there lots of people visiting family members in your facilities, or was that actually not that common a thing? In other words, how big a change has it been to do what you've described?
Oh, I think it's very similar to what you've seen in the skilled nursing facilities. The nursing facilities, they've restricted it. I would say that it depends on the patient. If you had burned your bridges, you might not have family, but most people probably did have family and visitation, I would say. Okay. I don't know if it was daily, like some that would, if you were in a medical facility, you would maybe have somebody even in the room with you. That was not possible. It's not exactly the same as in a general hospital, that there were visitation hours every day that they could have family, friends, significant others come and visit. So I'm sure that it's a tremendous difference.
Thank you.
Yes, ma'am, Commissioner Land, just continue, please.
Okay. So next slide, please, Heidi. Whoops, there we go. So there has been an impact on the facility finances due to COVID, and this slide shows that impact for FY 2021, so year to date 2021. It captures those reimbursable costs under the current buckets of federal money that DVHDS has asked for new appropriations for in 2021, and that's the provider relief funds, rural, and CARES Act funding. What's not shown on this slide is 1.4 million of provider relief funds that were carried forward from FY 2020 into 2021. And these provider relief funds were dispersed directly to facilities which are eligible to attest, which means that they are Medicare certified and or rural eligible hospitals. And the facilities have incurred other impacts that are not reflected here, especially with regards to the impact of staffing and having to meet all different types of things, whether that's additional shifts at overtime, hazard pay, shift differentials, those types of things, and for having to be able to attract our staff to pick up shifts so that we could continue to care for the patient. And what impacts that even more is that our facilities are funded at 90% capacity instead of 100%. So we continue to have some operational concerns that we want to help staff, and we've implemented a hazard pay plan, that's harder to say than you think, that's funded through the CARES Act funded, and that funding is going to expire on December 30th. So we'll be looking for other ways that we can try to address some of these staffing issues. Next slide, Heidi. So this is a look at our extraordinary barriers list. And as you know, that encompasses anyone who's been ready for discharge for 14 days or more, but who has a significant barrier or barriers that prevent a safe discharge. And you can see we started out and we made a pretty good impact, but it's bumped back up and we're working it back down. It's another roller coaster for us. it has continued to rise in recent years. We started a EBL work group in February, just before the pandemic, and the number of people on that EBL list totaled more than the overall capacity at 6 of our 9 state hospitals. That's not including, of course, the maximum security unit at Central State. But over those past 7 months, we've averaged about 81 discharges off of this per month. And that's up about 20 more discharges per month than the previous year. So we are making some headway. It's really hard when a lot of the discharge placements have closed to accepting patients. So you get blocked from even some of the whether it's a group home or a nursing home, they've closed to admissions on and off throughout the pandemic. It just really makes it hard. You can see some of those main groups of patients, or what I call the buckets, on that list on the slide, so you can see kind of where they're at, whether that's the NGRI process, and then that process has a host of passes that you have to go through to that show that you're able to maintain while you're on pass successfully as part of their treatment and moving towards discharge. And a lot of those activities had to be curtailed during the pandemic, particularly at the beginning when everything was pretty much shut down. So it also, we're seeing a decrease, though, that's important on the average length of stay of the folks who are on the EBL. That's also reduced about 10 days. So we're finding ways to move them out faster and more of them faster with this work group. And I've really maintained it. So we meet twice weekly, and I'm on every one of those to show that the support and to try to break down any barriers that they're seeing. And I think it's working, but it's still so high. So we're trying to make sure that that we continue to make progress. And
I'm sorry, excuse me. Has that definition changed in the last few years? For membership on the extraordinary barrier list, 2 weeks they've been ready to go home?
I think that, since I've known about it, that's what the definition's been, but we do have some other folks on. If it's changed at all, I'm not aware. Heidi or Mira?
Okay.
Must not be. But we are currently awarding a contract for guardianship, which is one of those you'll see, and conservatorship services, because that's sometimes a big barrier. We did enter into Exhibit Bs, which are performance contract exhibits with 3 CSBs for CSUs beginning in March, as well as 1 private CSU in Northern Virginia, and that's going to help. And we're also contracting on an emergency basis, like I said, with the assisted living and nursing home corporations. And we've tried to pick ones that have locations across Virginia so that we're not moving somebody all the way across the state to get them into a facility. And so we've had some good success with those as well. Next slide, Heidi. So we're engaging every strategy we can to address the overall census and to expand and balance the efforts on both the front and the back door, as you can see on the slide. And we've reconfirmed the existing agreements and developed 10 new agreements since December when I came on board. And we are very interested and continue to talk with partners. Every time I speak to a group or meet with a group, I'm letting them know that we want to partner to divert the TDO admissions for children, for adults, for geriatrics. We want to step down patients from the state hospitals to get that throughput going. We want to see more discharge planning and more community services from the CSBs and want to work with them. We want the community providers to help be brought in to help so that we can get referrals for appointments and things like that, so that we can more quickly discharge our patients. We need to all come together, public and private, to make this happen. So the door is also definitely open for crisis stabilization services, whether that's a CSB doing it or a private provider. But what this all really, I think, underscores is that Virginia needs more community services that can help us facilitate these safe discharges, not just from the state hospitals, but other inpatient settings, which when they get full, mean that those patients come to the state facilities. So we need everything pulling together to meet this challenge. Next slide, please, Heidi. So the additional discharge assistance planning dollars and pilot funding that has gone forward will support our efforts to reduce the EBL and safely discharge patients when they're ready. We've been working during the pandemic to establish several emergency contracts to divert or step down individuals, and this DAP and pilot funding will enable more of these partnerships. We've actually met with, we didn't get in total all of the pilot monies that we were going to be working on with VHHA for hospital census reduction pilot programs, but we did get half of it, and so we've already met with one of them, and so we are going to move forward on that, and we're just very thankful for the getting some of the DAP dollars back too. So thank you so much.
Mr. Chairman, Watts.
Delegate Watts.
Thank you. A quick question before we go on to the next section, and this is back on the slide that identified $11.3 million of COVID funding that's been received as of October 1st, or as of the end of October. Two-phase question is, does any of this expire at January 1? And of that might go beyond January 1, does it expire at the end of the fiscal year?
So it's my understanding that and I think we may have somebody else on to help with this, but it's my understanding that it is set to expire, but we were able to bring some forward into 2021. So I don't know, is Nathan or Andrew on that can help explain that? Because we were able to bring some forward, and but I don't know if we'll be able to, since I guess if they expand the date, but unless they expand the date, I don't know that we would be able to.
I would appreciate that follow-up, because that's how I should have phrased the question. Carryover beyond January 1, beyond the end of the fiscal year.
I think it will depend on if the emergency is extended nationally. Because
use of the funds we have thus far received, $11.3 million, will any of it be limited as far as not being able to be used after January 1 and or not be able to be used after June 30th?
So it's my understanding that the CARES Act funding needs to be spent and out the door on what we're going to spend it on by the end of December, that day, the December date. I don't know if they will allow any leeway on that and to carry anything forward into January, unless there's some sort of extension that's granted, but that would have to be, I guess, federally extended. So what I'll do is I'll get an answer to y'all, a better answer, but that's what I know currently.
And that's my understanding. If it's CARES Act funding, it has to be spent by the end of the year.
Right.
Exclamation mark.
Thank you, right. Chairman. And if I may, that was actually my concern. There is a lot of money sitting there, and I'm looking at COVID identified expenses of $2.5 million and wondering how we can utilize the remainder of the 11.3 million on the kind of issues that have been identified thus far in the presentation.
And that's through October 31st, and we are already continuing on with plans on how that's going to be spent.
Mr. Chairman?
Senator Howe.
If I'm remembering correctly, what we ultimately did in budget conference, the money needs to be basically spent by about the 20th of December, and any money that is not spent of the COVID money is going to be swept and given to the Unemployment Commission. But Mike Tweedy, I'm sure, knows better even than me.
Madam Chair, I think you're exactly right. That was my understanding.
Yeah.
Yeah, Mr. Chairman, to Senator Howe's point, yeah, and I think the only leeway that my understanding that the feds are providing regarding to it is you have to incur the expense before December 30th. So previously, they were actually very strict. You would have to have been out the door by December 30th, but you could incur the expense, which basically means place the order, receive an invoice. And if you don't pay the invoice until after December 30th, like within 30 days, they would allow that. But you still have to actually incur the expenditure for December 30th. And so to Senator Howe's point, what we had done in the budget was basically said that the governor can spend money on all these different items, but by the time he gets to around, and he can reallocate them if he doesn't think he can spend it in time, but by the time he gets to late December, around the 20th or so, anything left would go to the unemployment trust fund to offset its higher costs.
Okay. So Heidi, next slide. So there has been, of course, an impact on the DBHDS licensed providers and CSBs as well. So it's been system-wide. Next slide. So DBHDS is tracking cases in each of our 12 facilities and is providing a dashboard for cases for DBHDS licensed providers on our website. And you can see on there, on the slide, if you wanted to go out, we keep that up to date. And so DBHDS licenses approximately 1,100 community providers, and they're providing mental health, substance use disorder, and developmental disability services across the state. And as of November 12th, we had 1,612 positive cases within those providers. And 133 of those were residential providers had outbreaks reported, and then 63 total COVID-19 related deaths within those provider service offerings. We're very concerned about continuing to support the CSBs and private providers in addition to our facilities. And on November 6th, DBHDS, in partnership with VDH, has convened a DBHDS-focused advisory group for our providers, and that group is actually a subgroup of the COVID-19 Long-Term Care Task Force. And so we're going to be working together with our providers in the community and VDH to address their PPE access, testing access, and planning for vaccine distribution so that they'll be included in those plans. So we're hopeful that they can continue to be included. Next slide, please. Oh, you did. You beat me to it. DBHDS is tracking, of course, the impact of COVID-19 on behavioral health and developmental services delivery. And so we're tracking where services are being delivered via telehealth, for example, or where operations are temporarily suspended. We're also tracking any changes to capacity, including staffing with our providers in the community, changes to admissions and admission policies, and any kind of location changes that are happening. So we're tracking them among the CSBs and the private providers that we license. And those types of providers include case management, children's residential services, correctional facilities, day support programs, intensive community treatment, intensive in-home services, opioid treatment services, all different types, the ACT services, residential and crisis stabilization, respite, any type of residential and supportive services, we're looking at all of them. What we've seen is that the most widespread disruptions appear to be among the day support and residential services. And you can see up on the slide that we had 201 day support services have been suspended temporarily, and 27 residential and crisis stabilization services have stopped accepting new admissions or are completely temporarily suspending admissions. So you can see that lots of impact in those community providers as well.
Mr. Chairman, Delegate Price.
Delegate
Price.
Price. Okay, I'm sorry.
Yep, sorry. Dr. Land, wanted to ask, I know that you're measuring, and it says private provider and the programs with the CSB, and I think I saw that it said licensed. Is there any measure on the impact of COVID to those that are not licensed but might be working with the licensed professionals? Is that number inclusive of them?
This would only be for the providers that the DBHDS licensed or the community services boards.
Okay, so is it fair to say that there might be a potential even further impact for those that would not follow in that community? Okay, all right, thank you.
Yes, ma'am. And they're working to supply us with this data and sending in we've got a cadence for them submitting all of these different changes. And it's a burden. So I'm not sure if there are, if we didn't have a licensing relationship or a performance contract relationship, if we could enforce somebody submitting data to us that are outside of these. But you're right, absolutely right. I'm sure there's a lot of other providers out there that are experiencing issues. Next slide. So in particular, this shows that the CSBs have been able to remain financially stable over the last several months, excuse me. They've only been able to do that by reducing staff to match the program demand in programs that have been affected by the COVID-19 restrictions, so like the day programs, and quickly transitioning to telehealth for other programs. But they've also seen reductions in the revenue because of these changes and fluctuations. And so that's how they've been able to maintain this financial stability. And so they have, throughout the pandemic, they've continued to provide all code mandated services, and they are prioritizing the essential services. Particularly meaningful is the pre-screening and pre-discharge planning, as well as diversions from safe inpatient hospitalization. They did quickly transition to substantial use of telehealth and other alternative arrangements in lieu of face-to-face visits whenever it was clinically appropriate. And we continue to work really closely with them to ensure we're sharing information and supporting our system throughout the pandemic. Next slide, please, Heidi. So CSBs will be receiving reimbursement for PPE and telework expenses occurred in this fiscal year. They submitted for July and August. So that you can see the breakdown there of the expense reimbursement amounts for July and August. And we are actually working with them to continue to collect, and hopefully we'll be able to get additional months in this fiscal year approved for some funding. Next slide. Wanted to make sure for any of the joint subcommittee members that may be interested in understanding how the demand for the behavioral health services will grow as the pandemic goes on. There's some early statistics that show that deaths of despair are increasing, as well as fatal overdoses. There's also emerging evidence that individuals who've been infected with COVID-19 have an increased risk of psychiatric illness. And so, unfortunately, I think we will be seeing the impact of the pandemic for years to come in terms of the rate of mental illness and the need for treatment.
Mr. Chairman?
Senator Howe.
I'm just not familiar with.
Uh-oh. think you're on mute.
I keep doing that, sorry. I'm not familiar with the term deaths of despair. Is that the current, I don't know, euphemism for suicide?
Yes, it's related to specifically to the despair that they're whether it's the psychological or the financial impacts and those that are causing the despair that's leading to the suicides. Yes, ma'am.
Is that, Mr. Chairman, is that term then used generally now for suicide? I've never heard it before.
Mr. Chair.
So Delegate Bell and Senator Howe's question is out there.
That's what I was going to say. I was going to answer her question if I might.
But I'd appreciate it because I've never really heard that either. And I wonder if there are suicides that aren't deaths of despair.
Mm-hmm.
But Delegate Bell, if you've got the answer, by all means.
Senator Howell, my understanding of how it is used generally, and again, each speaker can use it however they wish, but it covers a variety of different ways that people pass, suicide being the most high profile, but certainly drug overdoses, people who engage in unhealthy behavior, and it has been used sort of as a catch-all for people who are finding themselves unhappy, taking steps that are unhealthy, and in aggregate, it creates deaths of despair. Now, again, I don't. If someone wants to use a different term, they can, but that's how it's been used, sort of in the popular literature.
Thank you.
Yes, ma'am.
Okay, next slide, Heidi. So wanted to share that in April, Virginia received grant funding from FEMA and SAMHSA to help respond to the behavioral health impacts of COVID-19 to develop a crisis counseling program. And so we worked with Mental Health America of Virginia and the Virginia Association of Community Services Boards and have established a brand new warm line that we've named for the Virginia COPES or VA COPES. And it actually provides an opportunity for any Virginian who is struggling during the pandemic to call the warm line and speak to a peer. So it's manned by peers who will offer emotional support, active listening, and actual referrals if needed for treatment. They do have peers that are Spanish speakers, and they're available whenever you call. And they're also able, though, the staff are, to connect with translators for additional languages if needed. And so as the volume increases, which we're seeing that it's increasing, VACSB is going to be a second provider of peers to help with the volume. And so looking forward to continue to work with them. And we did get an additional grant around this that's going to allow us just under $1 million that's going to allow us to operate the warm line through May 31st of next year. So that's good. And you can see the telephone number there. Would love for if you have the opportunity to share that with anyone that it could help. Next slide, Heidi. So the next part, I wanted to talk a little bit about STEP Virginia status and how we're continuing to build those core services during the pandemic. Next slide. So during COVID-19, we did make significant, we have continued to make progress. We've seen a new way potentially in some of these services. So you can see the 3 that have been implemented and then the ones that are underway. So we have already started implementation and are continuing to build those out. And then where we're hoping to go in this current biennium, and then our future steps, which those 3 will not be potentially until the next biennium. So we have seen that same-day access services has continued, and we're being provided using drive-up services and telehealth. We really do a lot of screening for symptoms so that we can keep it safe at the CSBs. The support for primary care needs and BMI screens are provided via telehealth as well. And we've actually gotten in some good data for the fiscal year of 2020. A total of over 60,000 same-day assessments were reported statewide. We also saw almost 78,000 primary care screens be done, and just under 35,000 metabolic screens. So getting some good utilization and access there for people. DDHDS is fully committed to building out all of the STEP Virginia services. But at the same time, we're having to take a hard look at what we truly need to implement those going forward. This is our path to bringing Virginians the robust, accessible, high-quality community services system that they deserve. And so we're going to continue to focus on this and to continue planning and implementing as much as we can going forward, even during the pandemic. Next slide, please. One part of STEP Virginia that I especially wanted to call your attention to is crisis services. And so we are currently in the middle of developing a stronger crisis system here in Virginia that will meet the needs of youth and adults in their communities by supporting them in the least restrictive environment that they can safely remain in. So the system that we're building includes a regional or statewide dispatch and call center, mobile crisis services, and crisis stabilization programs, which are a combination of our CTAC and CSUs, as well as the development of an additional continuum of support under behavioral health enhancement, including 23-hour observation, which we think will be a wonderful addition. Developing a system that truly meets people's needs as close to home as possible is a substantial task for a state of Virginia's size, particularly since it lacks a good deal of the existing infrastructure. I also wanted to, I know there's a great deal of interest in the Marcus Alert Crisis Response Bill. And that bill was, of course, largely a result of an advocacy effort led by the family of Marcus Davis Peters, who, as most of you know, is a 28-year-old biology teacher who was shot by Richmond police in 2018 in the midst of a mental health crisis. And so the bill is aiming to provide mental health response to mental health crises and reduce negative outcomes involving the use of law enforcement interactions when an individual is actually experiencing a mental health, substance abuse, or developmental disability or a related crisis, as opposed to needing a law enforcement intervention. Next slide, please. So the behavioral health response, when you look at Marcus Alert and the crisis services that we're looking at under STEP Virginia, it can come from community care teams, which would be a team of mental health service providers that could include peer recovery specialists and law enforcement in addition to the mental health providers, or it could be mobile crisis teams, which may not include law enforcement. The STEP Virginia step that DDHDS continues to work with the CSBs on planning, that is a critical step in STEP Virginia, and it will continue to meet the needs for infrastructure and workforce is going to be a high priority. We're going to have to figure that out to meet the goals of the Marcus Alert, as well as to continue to try to divert individuals from inpatient hospitalization. And I know that Mike Tweedy had already shared some of the funding for it. So in the funding for the planning and protocol development is going to be for one FTE in FY21 and 22. It'll be just a half a year really in FY21. $5 million in FY21 for the actual call center and the technology that's involved, and $4.7 million in FY22. 6.8 in FY22 for the mobile crisis services, the teams, and $3 million in FY22 for 5 Marcus Alert programs, which need to be implemented by December 1st of 21. So going to be a very aggressive timeline for us, but very, very critical, I think, to implementing this important step in STEP Virginia. And you can see on there the timeline. It's pretty aggressive. And if you need more information, I know we'll put more meat on these bones as we get into it. It's just been approved. So we'll be able to share more with you in future presentations on how that's coming along. Next slide. So this slide provides a snapshot of the steps, the implementation, and the funding. So the services that are highlighted in the green are those that were fully implemented. If you saw them on that step, the stair step slide, the ones in it looks peach to me, the peachy color are the steps that have been implemented but are still being built out. And so they're underway, what I would call underway. And then the last three are those future steps that are currently not funded. The far column indicates where funding ended after the special session. And again, Mike, I know, shared many of these numbers with you, but we are just very thankful that we received some of this funding put back in the budget. So hopeful that we can make great progress and really make a difference through STEP Virginia. Next slide. So we also have worked on a number of different work groups and wanted to share some of those takeaways from the work groups. You'll see on each of the slides that it'll put down. I put in the key goals, who all the different stakeholders. So I won't go through them each time. The stakeholders are, and then kind of the takeaways and the recommendations. So the next slide, we'll start with the medical TDO work group, which was charged with developing policies and procedures and to understand recent changes to the medical TDO code, which specifies that intoxication is a condition for which a medical TDO can be pursued. And the work group's policies and procedures are final, so they are available on the DBHDS website if you want to go out and look at them. The work group had a number of recommendations related to the process of obtaining medical TDOs, including needing further study into whether magistrates should have the authority to issue medical TDOs as opposed to judges, and what the specific responsibilities of the CSB are after the medical TDO expires. So the TDO evaluator work group is next. And that work group was charged with developing a comprehensive plan for expanding the categories of professionals who are able to conduct the TDO evaluations in Virginia. You can see that there was a wide group of stakeholders that met to discuss the different pathways and the challenges and benefits associated with each. The report is still under review, but two primary pathways were identified, and I'll go ahead and share those with you. One was expanding the categories of professionals who are currently on staff at CSBs who can conduct evaluations, and then a second pathway was allowing for physicians and licensed mental health providers to conduct evaluations when the individual requiring an evaluation is in the emergency department. So that would be emergency department or hospital staff. Each pathway would require careful planning and monitoring to ensure there's no inadvertent consequences, including increases to the state hospital census. The next one is the bed registry work group, and it was charged with reviewing the role of the acute psychiatric bed registry and making recommendations for its improvement. The work group agreed that various improvements were necessary to increase participation in the registry, which is fundamental to its efficacy. Some of the recommendations included interoperability with EHRs and bed management systems, which would be fantastic to reduce that manual updating and allowing for filterable fields such as clinical exclusion criteria to identify open beds based on key demographics and clinical information They also have asked for secure upload of patient data, an improved user experience, and several more. The report is final and available online. And you can see that where it's available at, listed on the slide, if you want to see the final. And then we have the DAP work group next, which was charged with understanding where DAP funds are going, identifying the effectiveness of the allocations, and making recommendations for creating services and housing for individuals that are leaving state hospitals. It's been finalized and posted online. Again, you can see on there where you can go if you want to go and look at it. It includes a review of DAP spending, and it was clear that they found that housing included supervised living options was a critical need for individuals that are leaving a state hospital, so in particular that housing aspect. The work group did make several recommendations, including rate setting for supervised living options and the development of services for individuals with dementia and traumatic brain injury, including NCOs in the discharge planning process was another recommendation, and there are others as well if you want to go out and read the full report. So next up are the DBHDS 2021 priorities. So first and foremost, you can see it's bolded and in a bit bigger type text. It's focusing on the state hospital census, which has been particularly challenged by the COVID-19 pandemic. So again, we're going to be looking at strategies to get patients to the least restrictive level of care where appropriate. And for example, I mentioned how we can better support individuals with a primary diagnosis of dementia. In addition, we're looking at how we assess and treat forensic patients, so that'll be a focus on how can we work on that census population. We also must focus on staff at state hospitals so that we ensure that we have safe staffing levels that are appropriate and reduce risk in the facilities. And again, we're looking at how we can do a better job of quickly discharging patients who are ready to safely return to the community through leveraging DAP dollars for appropriate housing options, including assisted living and nursing facilities. We're also continuing to work on furthering our progress on DOJ. And part of that means thinking through how we can support providers to strengthen the system-wide quality through licensing and other initiatives. We have made good progress on DOJ, even during the pandemic. And as you know, the availability of the community-based services across the Commonwealth is critical to meeting the needs of Virginians and reducing hospitalization and other expensive high levels of care. This encompasses continued work on Step Virginia, integration of the Marcus Alert requirements into our system, as well as working with our partners at DMAS on behavioral health enhancement, which will be critical to continuing to build out the community continuum and attracting providers to come into the market to deliver those services along that continuum. And so that's my last slide. And so just want to say thank you, and I'd be happy to take any questions, Mr. Chairman, you or your subcommittee members may have.
Thank you so much, Commissioner Land. Are there further questions?
Mr. Chair.
Delegate Bell.
You talked about it, and I'm just not sure I'm following the relation between the Step Virginia, and I might not even have the right lines, but mobile crisis and crisis dispatch with the new Marcus Alert. Are we going to be able to sort of fold these together? In other words, comply with the Marcus Alert law that passed? I know it had a fairly open approach to what the details would be. Or are those really different ideas? In other words.
So I think they're complementary ideas, and there's a lot of overlap. And so what I would say is that if we have a way for folks to not call 911 that's an appropriate and it's communicated and marketed so it's widely known, if you're in a mental health crisis or any type of crisis that's not law enforcement related, that you can call the our crisis center, and we can dispatch mental health professionals into the community to your location. We don't have to have law enforcement involved, and you don't end up necessarily in the ED or in the jail. So you get an automatic, potentially less law enforcement related outcome for those patients. And then too, if we do identify that we do need to have law enforcement presence, if they call the call center, then we can interact with 911 to get that law enforcement response. Also, on the other side, if they call 911, they will be able to triage. And so there's a lot of policies and procedures and coordination and all of that that's going to have to be done. And that's going to be a joint working on that with BBHDS and the Department of Criminal Justice and those folks. So if they end up with a call, they can triage it. And if they feel like that it doesn't rise to the level of needing a law enforcement response, they can either plug us into the call center, or they can, if they have the community team that can go out that has the mental health providers on that team and peers, then you can have a better outcome there as well. So I think it'll work hand in hand. But what you would hope is that we would be able to get more of a mental health response as opposed to a law enforcement response. Does that make sense?
It does. I think probably my questions are way down in the weeds. Just it's implementational issues. That's
right.
You've answered the question. Thank you.
Madam Chair,
Yeah.
I think that was a good answer. I mean, my hope when we were having the Marcus Alert debate is that we weren't deviating too much from our plans under Step Virginia. I'm hopeful that the Marcus Alert will help us move Step Virginia along. I hope they work in a complementary fashion.
Mr. Chairman.
Delegate, our Senator Howe.
Thanks. I probably have missed a step or two in here somewhere, but I hope that we will continue to move toward universal crisis intervention training for law enforcement. Is that still the plan?
I can try to answer. I do believe that there is language around that to cover it, yeah, and money.
Okay. I think it's a really important component of all of this, and Senator Deeds and I have worked on it for years, so I hope we don't lose it.
Mr. Chairman.
Madam Chair, I think that Senator Edwards had a bill that was scaled back in a way that still provides, and we provided some funding for it too, I think, for some mental health training for law enforcement officers. Is that right?
Mr. Chairman. This is Delegate Hope.
Delegate Hope, yes.
Yeah. In fact, Senator Edwards, and this was also part of the omnibus bill, and I had a bill as well too, that not only got to the police academy training, but also got to in-service training every 2 years. So we made certain that these types of trainings for people with disabilities, mental illness, is all part of that. So it's not just at the academy, but it's ongoing.
Thank you.
Mr. Chairman. Delegate Price.
Delegate Price.
Yes, Dr. Land, I had a question when it pertained to the Marcus Alert. I know that I've heard you say peers in the larger conversation, and I just wanted to know specifically if you anticipated that there would be a role for QMHPs or folks that are kind of like what I think of on boots on the ground within that, and just hearing different conversations about what licensed folks do, what non-licensed folks do, and how to best, how to best harness what people do on a day-to-day basis so that they could use that in an emergency situation.
So it's my understanding that when they build their teams, they will have a mental health person and definitely a law enforcement person, but that they also can include peers, and that was written into the language. So it just depends on, I guess, if they're able. Sometimes it's hard to get the peers because they're the fund. If you bill for it, you don't get it's hard to afford them also, because so you have to pay them a certain amount, but you aren't able to reimburse for their services at a level that allows you to cover the cost of it. So I think that there's been some, some folks aren't able to, some organizations have not done a lot with peers because of that, but that's also something that we're working on. So hopefully we can make an impact there so more peers will be used. But I think that that's sometimes, there's also an issue sometimes with the number of hours supervised to be able to be certified as a peer. That also, I think it's like 500 hours, that also may implicate and hurt the adoption of peers. But so those are definitely some of the things that we work on routinely to try to overcome those barriers. But yes, I would think that peers will be used. We just have to figure out the best way to do it.
And Mr. Chairman, just a quick follow-up on that. Okay, would that be, because I just want to make sure as I'm taking my notes that I'm hearing that. So then instead of, I guess in order to incentivize in some of those situations, would that be a reimbursement rate issue that could get to some of the potential obstacles that you just described?
I think that it would be two things. That first, I want to talk with and see if there's any ability to look and see if different service or what you're working at currently as a job would count for hours towards service, that we could make it easier for them to get their service hours in to get certified to be a peer. And so they could really be effective and work as a peer as opposed to having a different day job, if you will. But there's also the issue around reimbursement that sometimes it doesn't make it financially sustainable to hire and keep peers working if you can't afford to cover the cost of their salaries and benefits. So we work on both of those issues.
Thank you.
Chair.
Thank you so much.
Senator Barker.
Yeah, just to follow up on Delegate Price's points there. A lot of times on these types of things, and I carried stuff related to the qualified mental health professionals to get that started. You sort of have to get something started to build confidence and acceptance of it as a successful reimbursable provision of services. And then you can, once you've demonstrated that and demonstrated that it's reasonably cost effective, then often you can get the reimbursement system changed later. But you have to build confidence in that up front. And I think we're making significant progress on qualified mental health professionals right now. And I think we will be able to do it eventually. And sometimes what you do is you started out with providing reimbursement from Medicaid, and then you build it into the private sector as well.
Correct. Well said.
Are there additional questions? Well, Sarah, let's talk about our work plan.
Mr. Chair, you have one more presentation. We have Jennifer VACSB here to give you.
I apologize. We're gonna have Jennifer Faison talk from the Community Service Boards, make a presentation.
Yes, sir, Mr. Chairman, and I will promise to be brief. The one advantage of being a closer at these meetings is that many of the points that I may have had to talk about have already been covered. But again, my name is Jennifer Faison, and it is my privilege to serve as the Executive Director of the Virginia Association of Community Services Boards. And I was invited today to speak to you to provide an update on the impact of COVID-19 on the CSBs, some of the budget challenges that has created, and then other important issues or challenges. And in a nod to the late Alex Trebek, I will call that potpourri. Very popular Jeopardy category. And so I have had the opportunity to speak and present in a number of settings, and have spoken with many of you during the interim to talk specifically about some of these issues. For this group, I'm going to focus on some pieces that are specifically related to behavioral health, but still, as I know that you all are diligent about doing, keep tucked back in your mind that the CSBs are also the single point of entry for developmental disability services. So I'm going to focus on behavioral health, but recognize that's kind of a third line of business that we have. And I will start with some of the good news first. I think it is, I'm proud to say that your public safety net for behavioral health services has not failed you. CSBs have remained open for services and have been successful in providing all of their code mandated services through the pandemic. And I know that Commissioner Land had some slides there on CSB services, and I wanted to point out that some of the data related to the changes in programs, such as temporary suspensions or program closures, may not represent a point in time. So there may have been a temporary closure at some point, just to either reconfigure to telehealth or to figure out a different service delivery model, but have since reopened. So we have remained open for all of our code mandated services. And I'll talk a little bit about some of the adjustments that CSBs have made in order to accommodate folks. Certainly the flexibilities that DMAS and DBHDS very quickly moved to provide to the system were very helpful, especially specific to telehealth. And having those flexibilities and having that come online quickly really did allow CSBs to pivot and to figure out service delivery so that we could keep individuals engaged in services, not just because it's important for continuity of care, but recognizing that during a pandemic, you're actually going to have an increase in some of the behavioral health conditions that we would otherwise see, but may be exacerbated by the pandemic. We also, CSBs have been able to, because of the flexibilities, have even been able to expand services in certain areas, especially our outpatient services. The commissioner mentioned that the VA CSB has partnered with DBHDS and MHAB to help staff and administer a COVID-19 warm line. We're very excited about that, and we're grateful to be brought into that partnership as a way to kind of extend DBHDS's reach and to provide that warm line statewide. So that's some bright spots in the middle of the pandemic. I think it's always important to take some time out and recognize those. I will say, however, though, that these changes did come at a cost. Your CSBs, they operate 24/7 services, just like a hospital does. Not the same kind of services, obviously, but on an ongoing basis, 24 hours a day, 7 days a week. They operate residential programs, which are 24/7, crisis stabilization, residential programs for pregnant and parenting women who have substance use disorders, and on and on. And the CSBs, they serve populations of individuals with very complex needs, just like nursing homes do. And we have not been prioritized necessarily in the same way as, let's say, the assisted living facilities have, with an increase in their per diem, or with the access to PPE through VDH. And I'm not suggesting at all that these other entities are not deserving of these accommodations. That is not what I'm trying to say. I'm just pointing out that the CSBs in many ways have had to kind of muscle through some of these issues with regard to PPE and funding on their own. And the move to telehealth, I think you've probably heard that over and over again, really is a revolution in our system, and it happened in a very short period of time. The upside is that we are able to reduce no-shows, right, and all kinds of other really important things, and keep folks engaged. But we have recognized, and you all in the General Assembly have pounced on it and are making great strides. Recognize that not everyone has access to the internet reliably, and that not every person that the CSB might serve has access to a smartphone or a data plan that would allow them enough data or minutes to actually engage in telehealth. So we're really seeing the benefit of engaging by telephone only. And in order to mitigate some of that, the CSBs have been really creative in, so for example, opening their doors for a same-day access assessment, but in order to keep it safe, they might bring the individual into an unused office and have a telehealth encounter with a clinician who's in the same building, but on a different floor maybe. And that mitigates that issue where somebody might not have access to Wi-Fi, internet, or a smartphone, and allows them to safely engage in services. So we have seen a couple of other things that have been touched on, but I'll just emphasize is we're very concerned about the increase in overdoses and overdose deaths, as well as an increase in substance misuse in Virginia, specifically related to the pandemic. So we're very, very aware of those trends and are doing everything that we can to intervene and make sure that we're meeting folks where they are and providing that critical access to life-saving care. A couple of the challenges that we have faced in addition to reconfiguring our service delivery system in order to accommodate folks is that we've had a hard time accessing PPE consistently, and we that has eased a bit in the, I guess, the past couple of months, but we're very concerned with the uptick in cases in Virginia and across the nation and across the world, that is going to get tight again. And while the CSBs have managed for the most part to remain solvent during the pandemic, as the commissioner mentioned, we have had to absorb some of the costs through staffing adjustments and that type of thing. Some of the federal money has been very helpful. Any of the CARES Act money that went directly to the localities, the CSBs had a better shot at accessing that than they did accessing CARES Act funding that had to be applied for through a provider portal. And it's complicated, but there's a third round of CARES Act funding that opened at in mid-October that we're hopeful that the CSBs will be able to broadly access. Another blip that has happened recently is that the federal government provided updated guidance on the FFCRA, which is related to expanded FMLA and paid sick leave. And previous to that, there were CSBs who were able to exempt all of their staff from those requirements. And the federal government has made it clear that CSB staff, such as their IT staff, which are obviously essential to billing and to keeping the backroom operations up and running for the CSBs, can't be exempted. And so CSBs throughout the pandemic have been making appropriate accommodations to keep their staff safe and encouraging folks to stay home when they need it. But this change is different for the CSBs because they are attached to local government, which means that they cannot access the payroll tax offset that other providers who are required to provide expanded FMLA and sick leave are able to access. So a couple of bright spots, a couple of challenges. We're bracing, obviously, for the months to come. We have had a very close and ongoing relationship with DBHDS, obviously, throughout the pandemic, specifically around the state hospital census issues and the ability to access hospital beds when they're available. The commissioner mentioned delayed admissions, which, the state hospitals were never designed to be able to appropriately isolate and quarantine patients in a setting like this. So we understand the pressures and the census issues that are involved there specific to the pandemic. But, the bed of last or the census issues were significant prior to the pandemic. And we've just seen that exacerbated, especially when there are outbreaks and specific hospitals have to be closed to admission. So we understand and we've appreciated DBHDS's ongoing support in working through that, but it does create a bit of a log jam in other parts of the system. And we recognize, that this is obviously going to be ongoing, and until we have a vaccine that penetrates broadly, we're going to be kind of singing the same song for months to come. So we're very concerned about that, and hopeful that there will be some additional funding and flexibility to support continued operations and engagement in services. So we are, as Commissioner Land mentioned, and thank you to Mr. Tweedy for his thorough overview of what was included in the special session budget. I think in many ways it was difficult to keep track of all of the moving bits and pieces, but it was a very thorough overview. And we're grateful that the General Assembly was able to restore some of the funding back to the budget for community behavioral health services and for STEP Virginia in particular. But we're very concerned about the ability to maintain that throughout the 2021 session. The majority of the funding for that is in FY 2022, which, as you all know, means there's an intervening General Assembly session and a couple of revenue reforecasts that will happen prior to that money being actually allocated in FY 22. So we're concerned about it. We appreciate your commitment, and we're hopeful that you all will continue to prioritize, as you have in the past, behavioral health services. A couple of things I wanted to touch on just briefly. The questions that you all have about the Marcus Alert legislation, and Delegate Bell, I appreciate your ability to kind of really dig into the weeds quickly and understand some of the, or at least begin to imagine some of the ways in which this implementation is going to unfold, and what we might need to do to partner to make sure that we're successful with it. But you know, the legislation started off separate, kind of in its own universe, and it was eventually tied to STEP Virginia. And the way that I interpret it in terms of the implementation is it really is, in addition to STEP Virginia. Of course, it is, you know, it is important, and it is a bill that has passed, and we will partner to implement it. That's not in question. But it really is kind of an expansion of the original focus of the crisis step of STEP Virginia. And so, as you know, it requires the development of a set of protocols, which is absolutely appropriate for how to respond when there needs to be law enforcement involved. And in order to implement those protocols, we assume that there would need to be some sort of response mechanism. You've seen many of the CSPs undertake, in conjunction with their localities, some co-response models. And while it is not dictated in the bill how that response has to go, it's clear that there has to be some provision for what's going to happen when there is law enforcement involvement. And so we would anticipate that any funding that's necessary to execute that would indeed be carved out of the funding that was made available for STEP Virginia, because it is kind of an expansion of the original vision for STEP Virginia. And then a couple other things that just popped up while these conversations were ongoing this afternoon. I did want to touch on CIT. Senator Howell, I appreciate you bringing that up, and just want to continue to say that CIT isn't just about the assessment center. It's about the sequential intercept model, which also includes early intervention and diversion from criminal justice. And I think it's so important that we continue to focus on CIT as an evidence-based practice that has proven outcomes over a decade of implementation in the state. And I appreciate you all weaving that into this conversation. And then the other thing that I will say in terms of the peer question that Delegate Price that you raised, and then maybe a little bit about the QMHPs being involved specific to the Marcus Alert. I agree with the commissioner, of course, that in some ways it is a reimbursement issue. And Senator Barker, I think you're absolutely right. How goes Medicaid, then goes the state. And that is one way that we kind of add a level of sophistication to the workforce, specifically around peers recently, to further validate that and make it a reimbursable service. But I will say that there are some regulatory issues with the way that the service is described that make it challenging. And that's a conversation for a different time. We have engaged DMAS about that on and off over the last couple of years and are very interested in continuing those conversations because we do think that they would represent a critical component in many of the programs that we have. And then lastly, in terms of QMHPs, it's not specific in the legislation the type of behavioral health clinician that would be, if it's a co-response model with law enforcement, and the type of clinician that would be riding along or any of that. And I think that that level of flexibility is very helpful. But I will say, Delegate Price, that we are always interested in having our behavioral health professionals practice at the very outer edges of what they're able and capable of doing, because we do have such intense workforce issues. So I'm not saying that we want to fudge anything, but we do want to recognize that QMHPs are a critical part of our workforce, and to use them to the greatest extent possible. And with 8 minutes left in your meeting and 2 other agenda items, I will stop talking and entertain any questions that you all have.
Thanks, Jennifer. Are there questions? Okay, Sarah, let's talk about work plan. Here's my problem. You know, this is November the 16th. We are 11 months, more than 11 months into this year. We'll be back in session in January for a short session. It sounds like a 30-day session. We've got extreme bill limits. Many of us have already made commitments for a good portion, maybe all of that limit. And my concern right now is that we spend as much quality time as we can together over the next 6 weeks to figure out what, if anything, we're going to try to accomplish in the 2021 session. It seems to me that one thing we have to be thinking about is that the end of this study commission is next year. We'll have until next December, but it seems to me that if we are determined that there needs to be an extension or somewhere to hand this work off to, because the work will go on. There will be a constant need for work in the area of behavioral health and mental health. And it seems to me that we need some study. We're going to need somebody to be looking at this for years to come. And it seems that if we're going to create a place for this to be looked at beyond 2021, we need to be thinking about it for the 2021 session. So, sure, Delegate Hope.
I mean, I would second that. I know we've had this conversation multiple times, and I'm not always familiar with why we don't make this permanent, but it's probably financial. But that being said, I do think that this body needs to continue through the STEP Virginia process and to assess how that's going.
You know, I agree with you 100%. Too much of what we do as legislators is personality driven. When Senator Gartland was a member of this body, there was a permanent mental health commission. When he left, it was folded into the Commission on Healthcare. There was a subcommittee on behavioral health in the Commission on Healthcare, but I'm not, and I don't want to throw any stones, but I don't think they really focused on it. I don't think they had the staff to focus on mental health. So we either need, it seems to me that we need to decide if this work's going to go on. We need to decide to continue this study, to create an independent commission with independent staff, or to create some subgroup of the Commission on Healthcare with some dedicated staff. And there may be a fourth option. Those are just the 3 things I've thought about.
And I will speak as I have spoken before on this issue, if I may, Mr. Chairman.
Delegate Watts.
Thank you. Several of us knew Senator Gartland, Joe Gartland, well, and he was an amazing legislator. But having said that, that's a number of years ago.
It
And
is.
a lot of things have changed in mental health since then. If it was appropriate to roll it under the Health Commission, then I would strongly argue it absolutely, and we've got the history of what happened as it didn't really have the focus as it competed with a lot of other issues of healthcare, that if it was appropriate then, it sure isn't now, with the expansion of in healthcare treatment and awareness and the work that has been done in this last 4 or 5 years, I think absolutely proves the case that there needs to be an ongoing separate commission.
Well, let's think about that. Let's hold it. And we're hopefully we'll get together again as a commission, but we're going to have 3 work groups. And I'd like the work groups to get together maybe once or twice over the next few weeks and figure out the 1 or 2 things we can go forward with in 2021. Does that make sense?
Yes.
And then maybe we can get back together. Well, we can figure out what bills need to get drafted and we can make that decision. I think we just have a very short time to make that decision. But we can get back together. I've asked that a placeholder requested, and one of my 12 bills will be the bill that does whatever in terms of continuing this study in whatever format. But we need to. I would say let's think about that and let that be part of our last discussion. Does that make sense?
Senator, what we can do is we can go ahead and get a polling out this week to figure out the dates that the work groups can meet. As a reminder, we had the work group on involuntary commitment and mandatory outpatient treatment, Delegate Hope's bills, and also the system structure and finance work group and the sort of special populations work group. And I sent out the who had been sort of assigned to which work group months ago now. I'll resend that tomorrow and we'll get the polling out to identify the dates.
Okay. Now, an unusual situation, nobody signed up for public comment today. So it's not on your agenda, but that's because nobody signed up for public comment. And the world we live in where we're doing it all by Zoom, I guess that's the only way we can do it. We don't have room for spontaneous comment. But does anybody else have anything for the good of the order they want to add?
Mr. Chairman.
Delegate Watts.
Thank you. My question is, we all have very tight limits on our bills.
Absolutely.
And we've got a list of bills here that were referred to the commission by various committees where they were carried over. And I believe the deadline for action by the committees that carried them over is December 3rd. I was under the impression that if a committee acted on a carried over bill, that bill would not have to be reintroduced and count against our limit for bills for the 2021 session. Is it at all possible that we can look at any of the bills? I have one that I think is necessary authority given the presentation of the Commissioner Land that I would like to see acted on, but I assume it has to be by HWI,
right?
Not by this commission.
Yeah, this commission is not a standing committee of the legislature. My idea, and I'll admit that we are so backed up, in part because the special session went on much longer than I thought it was going to. But my hope was that we could have these bills considered by the work groups. I think that was the plan, wasn't it, Sarah, to get the work groups to take the bills up?
But it does the answer then, because of everything that we've all been through. We're all under that. That means that carryovers are essentially dead as of now, because the action to have a committee act by December 3rd is.
I don't see how you get a committee get a bill from this group to HWI and get them to act by December 3rd. I don't know how that practically works. Now, I can tell you that as for me, I'm in court just about every day between now and December 3rd. I don't know about everybody else, but I think each one of us has commitments that we backed up to the end of the year because we had to.
Thank you, Mr. Chairman. Again, I totally appreciate it. It just means that we may be limited on 2021 action on these bills because some of them are important in setting authority, but they're not game changers.
Well, your point is very well taken, Delegate Watts. I'm sorry as I can be that we didn't get to meet and get action on this stuff earlier. Does anybody else have anything? Well, I guess we are then adjourned. Thank you all very much.
Thank you.
You.
Thank you.